Good morning, everyone. I'm Sue Valillo. I'm Vice President for Clinical Services at the ADAMH Board. We are now going to move to a panel discussion about mobile crisis. These are teams as well as others operating in our community, and they are a critical next step to the 988 Suicide and Crisis Lifeline. When a crisis cannot be resolved on the phone and an individual is in need of in-person intervention, that is where the mobile crisis response teams play a role. Joining Dr. Draper on stage are representatives from 3 programs in our community. I am pleased to welcome to the stage Sean Daniels, Mobile Crisis Manager, NetCare Access, Valerie Coleman, Valerie Coleman, Peer Supporter Specialist, NetCare Access. Sergeant Matt Harris, Columbus Division of Police, Mobile Crisis Response Teams. And Jessica Michael, Clinical Lead Supervisor, MRSS, Nationwide Children's Hospital, and serving as and serving as moderator for the panel is ADAMH CEO, Erica Clark-Jones. Thank you.
Good morning again, and thank you for joining us for this panel discussion. I have a lot of respect for everyone on the stage. So we have a number of mobile response teams in our community. 3 are represented here with us today. Sergeant Harris, Sean Daniel, and Jessica, would you please share a brief description about your organization's mobile crisis response and include the composition of the team, hours of operation, and how they're dispatched? You can go first.
Okay. All right. So I oversee the City of Columbus Division of Police Mobile Crisis Response Unit, and we are composed of a police officer driving a cruiser, and then we put in the passenger seat a licensed mental health clinician, and that's called the embedded co-responder model, and we respond all over the city to psychiatric emergencies. And we've been running this program for roughly 5 years. We operate from 10 a.m. until midnight, 7 days a week.
Great. And they're dispatched?
Dispatched through, calls can come in through 911. They can come in through the non-emergency number to police dispatch, triage by our right response unit, and then we also take direct referrals. So not everything comes through 911. There are plenty of people that reach out to the teams or reach out to me personally and with a referral, which we'll then assign to a team.
Thank you. Sean?
Yes, I work with NetCare Access, and we have a mobile crisis team. Our co-responder model encompasses a social worker and along with a peer support specialist. We are dispatched Sunday through Saturday from 988, also from NetCare Access Crisis Line, but we are dispatched from Sunday through Saturday. We have 5 teams that are servicing all of Franklin County, and we are responding from 8 a.m. until 9 p.m. at night. And our co-responder model, our social workers always go out in a team of 2. We're never alone. And so we have been doing this since February. And we have definitely seen a huge increase in our call volume, probably about 75% increase.
And that's dispatched through 988?
Yes, okay. Dispatched through 988,
Great,
absolutely.
Thank you. And then Jessica, Nationwide Children's Hospital?
Hi, yeah. So I am one of 4 supervisors for our mobile response and stabilization services at Children's Hospital. Our team consists of licensed mental health clinicians, parent support specialists, and qualified behavioral health specialists. We're starting to dip our toes also into peer supporters as well. So for an initial crisis, we're sending out a duo that always includes a clinician and then one of those other roles. And we are running currently about 9A to 9:30 p. Monday through Friday, depending on kind of how late that final crisis comes in. We might be out a little bit later, but We've been open since August of 22, and like Sean said, we have absolutely seen an increase in our runs as well. We are dispatched, our calls kind of funnel through our telecrisis team at Nationwide Children's Hospital, and that's the Franklin County Youth Psychiatric Crisis Line. And those calls are either coming from community members or they're coming from the MRSS state line up north, the Thrive Center. So.
Great. Thank you. So, Dr. Draper, we heard in your talk that there aren't very many national standards set around mobile crisis at this time. But how would you either recommend or are there promising practices about how effectiveness on mobile crisis teams is being measured?
That's a great question. So right now, most of the mobile crisis teams are being judged by their diversion rates, meaning that they're keeping, to what degree are they not putting people in hospitals? That to me is not an effectiveness measure. That it implies effectiveness to the extent that it's saying we're avoiding an undesirable outcome, but it's not telling you about desirable outcomes. What's happening when a mobile crisis team is called to see someone who wants the following to happen? They want to feel less in crisis and less in distress, and if they're suicidal or they could be threatening harm to others, that they and others are safer by the end of the visit. That's also what the counselors want. Counselors are not coming to this home thinking about keeping people out of hospitals. If they need to go to the hospital, that's where they need to go. What they're thinking about is, how can I help? So what are our measures for determining what's reducing distress, what's reducing suicidality, what's stabilizing people in their home, and to what degree mobile crisis services are linking people to care? Those are the kinds of effectiveness measures that we need to establish for all of our teams and everywhere they operate.
Hear, hear. Hear, hear. I'm going to turn to Valerie now, and Jessica, I'd like you to weigh in too. But we're talking about peers, right? And these emerging models all include a clinician plus a peer. Valerie, how does your unique role as a person with lived experience make a difference in individuals' outcome? Kind of what Dr. Draper was talking about. What is your role in helping make sure we're getting a better outcome for the person?
I'm Valerie, of course. I feel that my contributing factor to going out is that I have walked in their steps, and that I understand the fear, and they're safe to talk to me. I'm not gonna judge them. I'm not gonna, write down anything against them. And I can also reach them where they're at. And I know that people that have, if you have depression or something like that, another person has it. It's just like an automatic thing. So I think that I've been very successful in getting people to go to the hospital or go to treatment, especially if you're at this level of you just can't go on anymore. And I try to let them know that you are in charge of what your treatment or what your outcome is going to be. I can't tell you what it should look like for you, but the first step is to get there. And I think the clinician with me is able to come from another perspective.
Great. Thank you so much. And Jessica, what are you thinking about? You're talking about parent peers, correct? How are you planning to use them?
Yeah, so our parent support specialists, we've been so fortunate to have them since we went live, and everything that she just said, they're able to get in there with the family, build those relationships, really quickly be able to build trust and rapport with the family and provide that support to the caregivers, whoever that might be, because we're not just treating the child in our case. We're kind of a family-centered care model, and we need to treat the whole family and give them that support. So it's just been fantastic to have them and have them be there. And I think also, kind of to piggyback on what you were saying, they're able to provide the clinicians and all of us other roles a lens that we might not otherwise have. And we're able to really kind of get that perspective from them and hopefully provide that better family-centered care.
Absolutely. It's so important. It's so complex as well. But you all make it look look easy. Before I go to Sergeant Harris, I want to first come back to Sean and Jessica. Maybe you can kind of keep the mic here. But when your teams are on site, what is the resolution of the situations that you are encountering most? What is the disposition of the individuals we're serving at the end of this visit?
Okay, so there's a variety of dispositions. Truly, when we go out, we have a licensed professional social worker that is going to assess the client just to find out where they are in that crisis. We're going to determine what is needed for this client. So that's our first goal, is to try to figure out what treatment is needed and sometimes required. Sometimes that can be a hospital. Sometimes it can be remaining in the home, pulling in other providers, other support family members. But it is definitely trying to meet the client's needs first and foremost in the least restrictive way. In the least invasive way. We want the clients to be able to determine that they are safe, that they are safe to reach out, but they are also safe and they are in charge of choosing where they go and what kind of treatment is received. So we allow them to make those requests known. We allow them to lead the process. So again, there is a variety of things that happen. Sometimes it is the hospital. Sometimes we do leave you in the home. But when we leave you in the home, we never just leave you and abandon you. We are coming back. We're going to circle back, and actually multiple times. We will circle back to make sure that we are addressing your mental status, that you are still remaining safe while you're waiting to get connected to treatment, while you're waiting to get maybe an appointment moved up for counseling, for therapy. We are waiting for whatever provider was recommended, that they are following up with you. So we try to make sure we're closing all of those gaps to make sure people are not left feeling like, okay, you made me a referral and now you're gone and I'm here and here we go all over again. Sure. So we definitely want to try to close that gap.
And are there times when you make referrals to your stabilization unit?
Absolutely. Absolutely. We still definitely always have an option to be able to bring them into our crisis stabilization unit where they're able to get treatment. They're able to get started on medications if needed, get back on medications if needed, get linked to treatment. Again, linkage is key here for a lot of individuals, but they just don't know how to get it. And when they do call, they get put on really long wait lists often. And so it's just sort of like trying to fix the system that is broken. And so we're out here trying to connect with our clients and get them into whatever treatment is needed. When they come into our crisis stabilization program, they can be there for up to 3 to 5 days, again, where they get more follow through.
Great. Thank you. Jessica, anything you would add to that for kids?
Yeah, I think in our program, everything Sean just said as well. And we also have kind of this 6-week span of time that following the initial crisis that might actually take us a couple days to stabilize, we're able to continue to come back for up to 6 weeks, whatever the family needs. That could be every single day in that 6 weeks. It could be once a week, whatever it takes. And we're really able to work on building those coping skills and all of those other interventions that they might need to continue to stabilize in the community. And then, like she said, with linkage, just making sure that they have all of those pieces in place. It's a tricky system, as we know. So that's what's been really fortunate to have all that time to work with to make sure they're set up for success.
Awesome. Thank you. Sergeant Harris, I know you've been waiting for this. So you all implemented a new co-responder model in the last year. And what are the barriers or the challenges that you see, things we can still work on as a community? Or you can talk about it as you see it inside the division.
So I'm going to talk about the barriers from the perspective of a public safety professional who's answering 911 calls, right? So inherently, when people are calling 911, it's not because everything's okay. It is an absolute last resort for most families. People don't want to call 911. Like the doctor said, there's a great concern about law enforcement showing up. And I understand that. I completely get it. From the context of these emergent scenarios where there are dangerous things potentially happening right now in the moment. Okay, I'll tell you the things that I see as barriers on the ground doing this type of work. And so I've got a couple bullet points. None of these are going to surprise anybody. I'm sure that these are going to sound very familiar. So the biggest thing that we see once we get that crisis stabilized, once we de-escalate, once the person, potentially puts a weapon down, climbs off of the roof of a building, whatever the case may be, opens the door where they've been barricaded inside of a bathroom for 3 hours, and they're endorsing suicidality. So once we work through all of those things, the main barriers are human resources, right? Sean mentioned that. The doctor mentioned that. It's no secret that Ohio has a huge shortage of psychiatrists. It is no secret that the wait lists for services, whether that is talk therapy, whether you need your medication adjusted, whether you had your first psychotic break and you need to get into to see a psychiatrist, yesterday. We hear this from family members time and time again. It is sort of a repeated theme throughout the calls that we go on. So, we get people to the hospital. The hospital's job is to stabilize and release, but closing that loop in the long-term care is where it can be very challenging. So another bullet point would be, we do have there's a handful of scenarios that are, I'll call them, high utilizers or repeat scenarios where people are trying their best and their care team is engaging them the best way that they know how. However, sometimes it's rare, but there are times where an individual's needs just cannot be met in the community, and long-term care is what is required. Those options are very minimal throughout our state. We hear this time and time again, and it's a sad situation because 911 gets called oftentimes, 20 times in a month, going to try to assist this family or assist a mental health consumer with an issue that just keeps cycling. Yeah. So we don't have anything that I've seen, or there's a gap with long-term care. The other bullet point that I'll talk about, and I know I'm kind of long-winded here, but there seems to be a siloing of mental health care when you compare it to physical health care. Mm-hmm. One thing that I notice as I drive my cruiser all over this county and all over the city of Columbus is that there are urgent care centers on every street corner, almost like CVS, Walgreens. But there's no real option for mental health care in an urgent situation. There are a few. Ohio State has a center, and NetCare opened their outpatient clinic recently, which is great. But when it comes to the EDs, the harsh reality is that they're overwhelmed. They're understaffed. We feel it when we walk in with a patient. We feel it every time. Yeah. Some days are better than others, but I think that the siloing of mental health care versus physical health care is a barrier. Absolutely. And I'll stop there.
Thank you. So I am cognizant of time. So Dr. Draper, I'm going to give you the last word. I mean, this is pretty real talk from everyone up here today. As you see, you've experienced the barriers. You understand the system from a high level. What do you see as the biggest opportunities?
I think when we think about what we can do specifically for mobile crisis implementation that can really make things easier for the providers and most importantly the people that they're serving is a couple of things. I'd say one, it really helps to have uniform dispatch levels. So from 1 to 5, 5 being, let's say, under these circumstances, you have to have a police response because there is a public safety risk that has to be managed, all the way down to a 1, very low risk, which under these circumstances, absolutely mental health care workers only, and all the way up to perhaps 4, we absolutely have to have mental health voices in as part of that response, if not exclusively that response. Even at level 5, to some degree, having some kind of mental health presence there is going to be really crucial in terms of bringing down de-escalating the situation. But if we know what's required in terms of who is going to respond at each one of these levels, then we can coordinate that care, determine through, let's say, a GPS-enabled dispatch, who's closest, who can provide this kind of care, so we can get them there quickly and have the right response for the right level of need. So again, that is done in a number of states. It should be done everywhere. And you should also have a technology platform that basically brings together all of your mobile crisis teams with the dispatch agent. So the dispatch agent knows where the mobile crisis teams are, and they can send the disposition back to hopefully the call center that's on the same platform, and they can follow up as needed. But there needs to be, if we're going to talk about air or care traffic control, there has to be uniform standards, in this case disposition or dispatch levels, and a means of communicating that is basically level set across the board.
Yeah. Totally agree. So much opportunity here, so much work to do. This is what I meant by, yet we still have more to do. And I mean, you've heard it. We know what some of the characteristics of our systems, long wait lists and other things. So we have a lot more to do together. I can't thank you enough. I know we could probably talk for another hour. However, please join me in thanking our panelists. At this time, we will move to the awards portion of our program. Again, I want to thank the panelists for their valuable insights and, more importantly, contributions to ensuring better outcomes for those experiencing a behavioral health crisis in our community.